I'm Dr. Yilmaz from MD Anderson Cancer Center Leukemia Department. So I'll be giving you a brief summary of the abstract that I'm going to be presenting today in ASH 2024. So in this abstract, we will be reporting on phase 1 and 2 study of the triplet combination, which consists of 3 drugs: decitabine, venetoclax, which is the backbone chemotherapy for acute myeloid leukemia patients who are newly diagnosed and who are not eligible for intensive chemotherapy, in combination with a drug called quizartinib. Quizartinib is a FLT3 inhibitor, and it has been recently approved by the FDA for that indication for younger patients, but with combination with intensive chemotherapy. In this abstract, though, we are looking the role of the same FLT3 inhibitor, which is quizartinib, in combination with a low-intensity chemotherapy, kind of chemotherapy that we know that are older AML patients that cannot tolerate the intensity. That's why we use low-intensity chemotherapy. That's the standard of care. Now we are trying to answer the question whether adding a FLT3 inhibitor to this backbone would make the things better, would make the response rates better, would make the patients live longer, would cure more patients than otherwise. So this is not the first report. We have reported the outcomes in previous years, but now we have more patients. So I'll be giving you the summary on the newly diagnosed patients, which makes things a lot simpler. So we treated 23 patients, median age of 70 years old. So these are older, newly diagnosed AML patients. And on those patients, they all have a mutation called FLT3 ITD mutation. So FLT3 is one of the common mutations in AML. About 30% of AML patients do present with this mutation. And we know that the FLT3 mutations are poor prognostic, meaning if patient presents with a FLT3 mutation, although response rates are similar, these diseases tend to come back quickly. So we incorporated an inhibitor of that FLT3 mutation into this clinical trial. So right now we are in the phase 2 portion of the study. So the earlier phase is completed. Now we know which dose to use, and we are going to be using this optimal dose in a larger cohort of patients. So far we have treated 23 patients. They are newly diagnosed patients. And out of these 23 patients, 22 achieve remission. So that's spectacular results. So that's normally the expectation with the chemotherapy backbone only, which is the decitabine venetoclax, is about 70%, perhaps 80%. Now we are pushing it to the 90% plus. So also not only morphological response, morphological means we are looking under the microscope and see elimination of the leukemia cells. This triplet combination generated deeper remissions when we do a test called flow cytometry, which tells us about the minimal residual disease status. 80% of these responders achieve this MRD negativity, meaning undetectable disease in the bone marrow. So this trial is still ongoing, although the trial started about 3 years ago, and right now we have a median follow-up about 20 months, slightly more than 20 months, and the median overall survival was not reached. So what that means is that we follow about 20 months, still more than 50% of the patients are alive. Actually, to be specific, 2-year overall survival is 65%. To give the comparison though, obviously not 100%, but to give the comparison understanding, normally with the standard of care treatment with decitabine and venetoclax or HMA venetoclax for the FLT3 ITD mutated disease, the median overall survival is only 12 months. So now we are pushing it, perhaps doubling it soon with this small study. Caveat is small, still we need more patients, we need to enroll more patients so we can gather better results. And so far, out of these 23, 4 patients relapsed, meaning their disease came back. And when we look at specifically which patients relapse, these are the patients with the high-risk disease. These are the patients that has a mutation called RAS mutations in their leukemia cells, 2 of them, and one had a TP53 mutation, which is also a high-risk mutation, and another called MECOM rearrangement, which is a high-risk. So patient with high-risk disease all 4 relapses were the ones who had high-risk disease. So yeah, this is pretty much the bottom line summary of the study, which still continues. And so far, patients, in terms of side effects, let's touch on that as well. So in general, the main side effects are not different from the backbone chemotherapy that we typically give. The one unique side effect that we pay attention is the QTc prolongation. So what that means is that the quizartinib is a drug that can cause rhythm problem in some patients, and a specific EKG abnormality called QTc prolongation. That's why we check our patients' EKGs multiple times in a week when they start on treatment, to make sure that the QTc doesn't get prolonged, so our patients doesn't get into a big arrhythmia. So far, we have seen none, but this is because we are doing vigorous, monitoring, and so far though it's manageable side effect. And the other to keep in mind is the prolonged cytopenia. So what it means is we start the chemotherapy. Typically, with the backbone chemo, only patients recover their counts between day 30 to 35 of the induction, but when we give the triplet, recovery happens between day 35 to 40 range. So let's say about 5 days later. So that's the one noticeable side effect. But other than that, not any major toxicity signal with this program. The drug that we are using is a drug called quizartinib. And again, this is a drug that has been approved by the FDA recently. And it's a second generation FLT3 inhibitor. It's a more potent FLT3 inhibitor. It specifically targets the ITD mutation. So what happens is in patients with FLT3 ITD mutated AML, the mutation occurs on a receptor called FLT3. We all have this FLT3 receptor in our bone marrow cell in the earlier life of the bone marrow cells. We all have it. But when this mutate, normally the receptor itself has a mechanism to switch on and off. And there's an called autoinhibitory function of this receptor is there. But when there is a mutation, this function gets disturbed. So that receptor become constantly active. It just constantly sends signals to the downstream pathways and makes cells to proliferate. And then that's why leukemia happens. And that medicine blocks that signal. That's how it works. It's pretty falls within the standard. We don't make our patients to stay in the hospital longer because they are receiving triplet. No, it really doesn't change the way we admit, discharge, or monitor. So it's pretty much the same. It doesn't add anything. And what it adds is just patient needs to take one additional pill. So part of this treatment, perhaps patients would wonder, is that the transplant, so bone marrow transplant. So obviously, as I mentioned, the median age is 70 years old. So this study designed for older patients. But there are some older patients we can, do transplant. So with the FLT3 ITD disease, once patients achieve remission, the current, as of 2024, current consensus is that patients should go to transplant. If they have a donor, they're eligible, they're performance status, physically fit, no organ dysfunction, that would be the recommendation. But there are some patients, they are old, they may not have donor, there might be some other reasons that they cannot go to transplant. Where this actually study comes in, so those patients who couldn't go transplant in our study doing relatively well. So because we keep them on the triplet regimen, and perhaps they are how we call it maintenance treatment. So they start the drug with the triplet drug, and we continue. After a year of therapy, we continue therapy more depending on how patient tolerates. So we look at two things. As long as the leukemia is in remission, and as long as the treatment we give is not harming patient by any means and tolerable, we continue. And we dose adjust down the way, meaning we dose reduce either of the drugs depending on the patient tolerance, but we make sure that it doesn't affect patient quality of life. Otherwise, it's going to defeat the purpose, right?